Right, so good afternoon. On behalf of all co-authors and myself, we would like to thank SAGES and the program committee for the opportunity to present our work here. And our moderators for their time also here. And then we would also like to thank the audience for their attention in advance. So over the next 8 minutes or so, we will be talking about some of the relationships between sleeve gastrectomy morphology and long-term weight loss and reflux outcomes. In terms of disclosures, Dr. Abbas serves as consultant for Intuitive Surgical, and Dr. Caton has industry relationships with, I thought I did that, sorry. Has industry relationship with Ethicon, Gore, Medtronic, none of which are relevant for the study in this doc. The remaining of co-authors, including myself, have nothing to disclose. According to estimate from national level databases, we're now about 59% of all the metabolic operations we do are sleeve gastrectomy. One outcome of interest, of course, is weight loss, and additionally, over the past decades, we've learned quite a bit about the relationship of this operation with reflux. Interestingly, there is heterogeneity when it comes to reported outcomes in long-term weight loss outcomes and reflux as well. There is also evidence suggesting that the way we do these operations may impact outcomes. And though differences in outcomes likely result from the complex interaction between patient-dependent and independent factors, we set out to investigate the potential impact of sleeve gastrectomy morphology as determined by postoperative day 1 upper GI on long-term weight loss and reflux outcomes. For our morphology assessment, we used previously published methodology by Toro and colleagues. They used a 4-category system defining sleeve as dumbbell if contrast fill the upper and lower portion with a reproducible narrowing in the middle. Lower pouch morphology for sleeves with a tubular upper portion and contrast mostly pulling in the antrum. Tubular morphology was recorded if near uniform distension was observed of the sleeve. An upper pouch classification was given if proximal dilation with a narrow distal tube was observed. Ours was a single institution retrospective study. We started with about 268 patients that underwent primary sleeve gastrectomy from 2010 to 2012, performed by 3 surgeons. 178 patients were excluded given the lack of long-term follow-up. And our final patient population included 90 patients, of whom 50 had available upper GIs on postoperative day 1. Sleeve morphology classification was independently performed by a radiologist and a surgeon by looking at fluoroscopic images. And of course, they were blended to patient factors and outcomes. And then when disagreement occurred, radiologist's classification was used. So inter-rater reliability was 92%. Follow-up was about 8 years, and baseline patient factors included age of 45 years, female sex in 83%, and 18% of patients undergoing a hiatal hernia repair at the time of index sleeve. As expected, weight loss and resolution of obesity-associated diseases was significant in follow-up. When we look at the overall sleeve morphology distribution across the sample, an interesting finding was that A-specific morphology was not favored. And you can see these proportions are relatively equivalent across morphology categories. And if we now look at the 2 surgeons with enough imaging studies to do statistical analysis, the same observation is evident. And when we compare those 2 samples, we can see that they are statistically similar. We did look at calibration device, staple line distance from the pylorus, and whether a staple line reinforcement was used, but we detected no association between these factors and a specific morphology. Our primary outcome for weight loss was BMI change. Dumbbell morphology was linked to lesser BMI reduction, and lower pouch classification was correlated with greater reduction in BMI. Age, sex, and whether a hiatal hernia repair was done at the time of index sleeve had no association with the magnitude of weight loss. Also, a primary outcome, the presence of any reflux at follow-up was defined as a documented diagnosis and the use of medication. Our data showed that the prevalence of GERD was significantly higher at follow-up. It included de novo in 51%, 28% with persistent, and 58% of patients with worsened disease. GERD resolution was experienced by 14% of patients, and 11% of the sample underwent a reoperation for medically refractory reflux. Sleeve morphology, age, surgeon, preoperative BMI, and again, whether a hiatal hernia repair was done at the time of index sleeve had no impact on GERD outcomes. Interestingly, patients with reflux postoperatively had superior weight loss, and there was a small but significant association between female sex and worsening of GERD. We did look at complications at 30 days, mostly to see if some of the differences in weight loss could be traced back to a rough postoperative course early on. And though we could not do statistical analysis given the low occurrence of these complications in the small sample, we did not, except for perhaps an observational trend towards higher complication rate with inpatients with tubular sleeve, we did not see anything else. Our study has some limitations. The retrospective nature of the work is exposed to all the biases associated with this design, but it did give us the opportunity to look at long-term outcomes. Our sample size is small and provides an opportunity certainly for validation with larger studies. These are single institution data which limits generalization in exchange for the ability to get granular with data collection and really be able to define our primary and secondary GERD outcomes and also look at sleeve morphology. And our reflux outcomes were defined clinically, which again provides an opportunity for future efforts to correlate these data with more objective like pH data. So our data shows that assessment of sleeve morphology by upper GI is feasible with high inter-rater reliability. We did not see a significant association between the technical factors captured by our study and sleeve morphology. Lower pouch category was correlated with higher BMI reduction, and lesser BMI decrease was observed with dumbbell classification. We did not uncover any associations between GERD and sleeve gastrectomy morphology. And very interestingly, patients with reflux postoperatively ended up losing more weight, and there was a small but significant association of female sex with worsening of GERD. So ours is the first study showing an association between sleeve morphology and long-term outcomes. Our data suggests that the ability to consistently generate the same morphology may be limited by current technical standards. Future research in this arena could concentrate on refining the techniques for radiographic assessment of sleeve morphology, as well as validating these results in larger patient samples, perhaps using a prospective design, and also in creating new technologies that may enhance our ability to achieve the same surgical product. The goal is that of optimization and standardization of surgical technique with the target of consistently generating the same surgical product for our patients. Again, we want to thank SAGES for the opportunity to present today and the audience for their attention, and I want to make sure we save some time for questions. Thank you.